webinar number 247 of the Andean Organism of Health. It's now been 4 years of exchange continues since we began this webinar in May 2020. This webinar is the second of a special cycle of webinars that are being done in synergy with the Copenhagen Institute for Future Studies. In 1971, with the creation of the agreement Hipólito Unanue, governments of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela joined in solidarity and regional integration to build a bridge for health to peace and work for the well-being of their people. Therefore, today, the Andean Organism of Health Agreement, Hipólito Unanue Agreement, continues its work with the Ministry of Health of the 6 Andean countries to materialize this, to make a reality this right to health. With this technological globalization, the COVID-19 pandemic reaffirmed the relevance of the health sector for the life of well-being. As such, nowadays it constitutes a priority to keep health at the center of all policies and social conscience, to join for the common good and to proceed towards a society that takes care of life. Health, therefore, is a bridge to achieve integration and peace. We invite you to read the bulletin Notisalud Andinas, released monthly, where we have these reflections as well as other relevant topics to health and well-being of our population, and which is available in the webpage of the Organismo Andino de Salud, Andean Health Organization, and in the part of knowledge base of Integración Andina. And now we invite you to put your name, organization, and country of which you belong to via the comment box of the chat of Facebook of YouTube Live. In the same space, you can leave your questions and you can send them via the following email address: webinarhorasconu@gmail.com. To access this certificate of assistance in this webinar, you must fill out a brief survey and leave your information on the link that is in the chat for Facebook and YouTube Live during the development of this event. We also remind you to verify that your email is correct, because this way we will send you the certificate. This webinar has the following dynamic. We will begin with institutional salutations, followed by the magistrate conference, and then we'll begin the dialogue with the comments of the representatives of Ecuador and Colombia. And then we will continue with the questions left by our participants. Well, now we shall begin to this meeting today by giving the podium to Dr. María del Carmen Calle Dávila, Executive Secretary of the Organismo Andino de Salud, Hipólito Unanue Agreement, Horas CONU, who will give now some words of welcome. Welcome, Dr. Calle.
Muchísimas gracias, Gloria.
Thank you, Gloria.
El Día Mundial de la Salud Mental
The Global Health Day that is celebrated on October 10th. Today we are October 10th, and it is celebrated every year with the objective of creating awareness on the mental health problems all over the world and to mobilize health efforts on global health. The topic of today, of this year, is it's time to prioritize mental health in the workplace. Numerous studies have shown links between these conditions that are psychosocial in the workplace and employee mental health, which is why safe and healthy work environments can act as a protective factor for mental health. Unhealthy conditions, stigmas, discrimination, and exposure hazards such as harassment and other poor working conditions can pose significant risks that affect mental health, the overall quality of life, and consequently, participation and productivity at work. Anxiety, depression, and other mental health problems have a direct impact in the workplaces by increasing absenteeism, reducing productivity, and increasing health care costs. However, stigma and lack of mental health awareness persist as barriers to address mental health in the workplace. PAHO notes that with 60% of the population of the world working, urgent action is needed to help mental health and to protect mental health at work. Employers and co-workers in the workplace can be agents of change by fighting stigma and encouraging open discussion regarding mental health. They can also learn to identify common mental health problems and also encourage colleagues who may have these difficulties in seeking help. The Andean Organism of Health, via this webinar, seeks to add to these efforts that are made by the governments, employers, and representative organizations that are working to create policies to prevent risks for mental health, promote the well-being, and create places of work that provide support where mental health is prioritized. To this end, two excellent speakers have been invited to share their experiences on this important topic. Dr. Charles Alesi, Medical Director and Editor-in-Chief of Health in the UK, and Dr. Dimitar Georgiev, Founder and CEO of Parallax Life as Bulgaria, who will be presenting since Colombia and Ecuador. Welcome, one and all. Thank you very much. Thank you, Dr. Acalle. And now we have the honor of having the presence of Dr. Puya Yesar, Doctor of Copenhagen Institute for Future Studies, who will have also some words and also provide the institutional salutations corresponding. Welcome, Dr. Bochi. Yes, welcome, and thank you very much. It is a great honor to be once again here in this forum, and with professionals who are committed to health, and also have the honor of having two great friends and great professionals in this area for whom I have great respect for their work. And they can provide us guidance on this very relevant area. And as Dr. Maria del Carmen said, it is something that we need to reinforce in daily for everybody. It is an area that we forget sometimes, and we're not taking seriously enough when we work with mental health for everybody. And our title is Stress and Resilience, Reinforcing Mental Health at the Workplace. Nowadays, we use a good part of our work time, of our life at work, and we know a lot of stress comes from work. So how can we focus in improving things, but also thinking about when there is stress, how can we change this for a greater resilience and reinforce and strengthen people? In this regard, there's also a part that has to do a lot regarding stress in our health sector. And I believe that in all presentations, they are focused because we also have to, we have an issue that this health sector also crosses stress, and we need to focus on that. There are many opportunities as to how we can work with this part. Today we have seen, up until now, we have seen growth in challenges that grow enormously, and we do not know how to react to them. We know that part of this is probably due to new technologies, especially digital, but we can also take resilience and use new technology to reduce stress and reinforce people. And that is a challenge. And with these words, I wish to begin focused on well-being and resilience. And we have great professionals, as was said, Dimitar and Charles. And I'm going to ask Charles to begin, or perhaps you, Gloria, will begin. Then Charles will begin. Thank you very much, Doctor, for your words. And after the institutional that is represents, my name is Gloria Lagos Izaguirre. I am from Cooperación Internacional and coordinator of the Interim Committee of Mental Health of Orozcono. In this matter, I have the pleasure of being in charge of moderation of this webinar. Although with this further ado, as Dr. Eliasen has said, I now give the podium to Dr. Charles Alesi. He is a leader, a medical leader in management of health. My apologies, she's saying. In health management, both in primary and secondary care, including senior leadership positions in very important such as the Ministry of Health as well as independent bodies. He is an expert in mental health and has extensive experience in health systems integrating health and social care, personalizing wellness, international regions such as Europe, the Americas, the Middle East, Africa, and Asia. He has worked independently in the reform application of technologies in health. He has occupied leadership positions in on various health matters, including the NHS, and has collaborated with political leaders and experts in international events to develop health policies. Dr. Alesi has presented evidences in front of the Health Committee of the United Kingdom and the Health Committee of the Commonwealth of Australia, and has provided an MBA course, and he has also taught an MBA course in Windsor, Ontario, specifically focused on introducing innovation in health and healthcare. Welcome, esteemed Dr. Alesi. Please proceed with your presentation.
Thank you very much for having me here today. And I want to thank my friend Bowie and also your esteemed organization for giving me the honor of some space to talk to you a little bit about issues to do with mental health, especially on a day like today, which of course, as we know, is Mental Health Day. I have a presentation. Is it possible for it to be projected, or shall I try to project it?
Adelante, por favor.
Please proceed. You're authorized to project it.
Charles, you do it.
Can you see my presentation? Yes? Okay.
Sí, se mira perfecto.
Perfecto.
We can see it fine, yes.
Thank you very much. So today, I really want to talk about mental health, one of the most ignored of conditions within non-communicable disease. And really the first question, I think, is why do we focus on mental health? And to do this, I really want to try to explore mental health in different dimensions. How common mental health is in disease burden globally, because of course these issues are present in all countries on earth. What's the role of mental health in the context of other non-communicable diseases? And of course, it would be unhelpful not to consider what the contributing factors are, because of course we have to end up with thinking in terms of some solutions, as well as identifying what the problems are. So I go back in time, but nothing much has changed. And mental health really is the elephant in the room. It is the condition which is present in a lot of presentations between healthcare professionals and citizens or patients, but it's a condition which we have marginalized. We even have mental health hospitals as against hospitals for all other conditions. The marginalization is actually quite significant. And I don't think really in this age of personalized medicine, it is helpful to continue down this line. We are seeing the effect of this, of course, upon our workforce, because today we're talking about our workforce, remembering the forgotten. So, as I said, mental health is one of the commonest conditions that presents, even on its own, in mild forms, as depressive illnesses, and of course in the more serious and enduring mental health problems. But we're still left with a situation where there is significant stigma. And that stigma perhaps is even worse amongst clinicians, because of course people still try to be the heroic clinician who doesn't actually get affected by all the interactions with the patients that they go through every day, which inevitably, however well trained we are, have an effect upon us. And we're seeing the effect of that, of course. We know that mental health is still undertreated. We know that compared to a lot of other conditions, it's still poorly understood. And we also know that the treatment episodes can be really quite prolonged and can include therapeutic intervention, i.e. drugs, chemical drugs, in other words, but also talking therapies, psychological inputs, and affecting the environment can have a significant effect. But we'd better get used to managing mental health, because clearly, if we look to what's going to happen in the future, and we look towards our Gen Zs, in other words, the people who were born after us, thank you for that wonderful introduction I had around all the stuff I did, but I did all that stuff because I'm old. But if we look at the young doctors, if we look at the young nurses, the level of and point prevalence of mental health conditions is significantly higher. If we look at our children, mental health issues are an even greater problem. So we'd better get used to managing these conditions better. So let's talk for a second about their place in non-communicable diseases, because we know, sadly, that we're still practicing medicine the way I describe it, medicine by body part. Because if you have a cardiovascular problem, you go and see the cardiologist. If you have an orthopedic problem, you go and see the orthopedic surgeon. If you have a renal problem, you see the nephrologist. And the problem, of course, is that not enough people are actually being managed as people within all their conditions. And also, of course, we need to understand that as these conditions develop and our general condition deteriorates as we age, or as the condition deteriorates when we're younger, clearly there is a mental health component to the treatment and management of all these conditions. And sadly, we don't actually incorporate that as much as we used to. But things could get better and actually are getting better, because the fact we're personalizing care so much makes it more likely that mental illness will be recognized and treated. So it's not all bad news. But let's look to now what the contributing factors are. In other words, what are the things which actually exacerbate or make the condition of mental health stress worse amongst our workforce? I think the first thing, the obvious thing, is the workload. Mental health professionals have now got used to being asked to do more and more in less and less time. And that in itself is a real issue. Because as all medical professionals and nursing professionals and health professionals are in general, they always try to do the best job they can. And clearly, with having more data input associated with what they're doing, recording of records, accessing different systems, it gets more and more difficult to maintain that human relationship, which is at the heart of caring and at the heart of a process of actually managing healthcare for people. No doubt this is made even worse by the fact that we're having significant problems on a global basis. In South America, as in Central America, as in Europe, as in Asia, everywhere around workforce. Because I say workforce, what workforce? There's less and less people who are now getting engaged in managing healthcare. And because of that, of course, there's more pressure on the people who are left. And because of that, there's even more pressure on their workload. And that is a significant problem. And of course, all this leads to burnout. And burnout is something which sadly we're all getting used to living with. Burnout of health professionals is a very significant problem. To a degree, digital transformation has partly been responsible for burnout, not because in itself it's responsible, but because of the way it's been deployed, the way it's been introduced. And in many cases, it's put more pressure on health professionals, even though it has the capacity to reduce that pressure. So not understanding quite how to deploy is a problem in itself. But also is clinical decision support. What do I mean by this? When I first became a clinician, what was really important was for me to remember about a dozen pathways of care. When somebody came into an emergency room in a hospital, how many drugs did we have? I don't know, 30, 40. Those were the common things we always used. And really, it was relatively straightforward to ensure that somebody was safe, somebody was free of pain, and somebody was managed until the next morning when they would be managed better by the team who accepted and took the care forward. And compare that to a situation now of an average clinician, be they a nurse, be they a doctor, doesn't matter who they are, where because of personalization, we have a multitude of care pathways. And because of this multitude of care pathways, there is increasing pressure on the health professional. One, to find out which pathway to use. Secondly, to remember the pathway itself. I could barely remember a dozen. Now there are thousands of these. How on earth can we expect clinicians to remember these? How on earth can we expect them to deploy these in a 10-minute consultation where they have to input data at the same time, the pressure is immense. So we clearly need some decision support for clinicians to remove part of that pressure on them. And as I said, the specialization is making it even more difficult for people to try to do everything. And that is what they're faced with every day. Hence, the high levels of burnout. And I don't need to tell you about the levels of burnout we're seeing with, mental illness being present in as much as 4 out of every 10 health professionals. It's probably more prevalent than that, but we tend to ignore it still. But we have a significant problem that we need to manage. And we also see this, of course, in the effects of burnout, mainly in depersonalization. And by depersonalization, I mean it's a pretty awful condition where the clinicians tend to feel as though they're dealing with people in a way whereby they're not actually part of the world that the other people are within. And it really is the start of the breakdown, which we see with burnout. And we see this actually, or degrees of this, quite commonly now, where people talk about patients as being a completely different tribe rather than something which lives in and people which live in a community where we live as well. And we also, of course, tend to forget about the COVID pandemic, because the effect of the COVID pandemic upon our medical professionals has been immense. Seeing those numbers of people pass, seeing the numbers of people fall ill, die, and the concentration of people will inevitably have had an effect upon our medical professionals, who also inevitably would end up with having elements of PTSD associated with that. Post-traumatic stress disorder, in other words. This is inevitable given what happened. So, okay, I talked enough, I think, about contributing factors. Let's talk now about something more important. And what that's more important is solutions. What are we going to do about all this? Clearly, we need to address the contributing factors, and I'll come to that in a second. But there are some other things we need, or people have tried, which actually do seem to work. One is setting up therapeutic groups and spaces for health professionals to actually come together as part of their normal workload. So you have a session every week as a health professional whereby you're in a group with others talking about your experiences, your difficulties in seeing patients, your difficulties in actually managing care. And as long as the agendas are actually set up by the people who actually attend, and there is a good facilitator in all of this, they can take any sort of shape, but in essence, they are a safe space for people to share their problems. This is not really that dissimilar to the approach we take for other enduring conditions, everything from alcohol abuse, drug misuse, the list is endless. So that approach has been proven to actually make a difference, to help our health professionals. Of course, it would also be helpful to have a direct referral service, an old-fashioned face-to-face one, as well as utilizing personalized digital solutions to do that. In other words, allowing people to actually access talking therapies to assist them in actually managing the stress and the anxiety associated with the management of conditions around they see every day. But it also is important for us to influence the regulators. And by us, I mean governments and health systems. And by regulators, I mean the people who license doctors, the people who are associated with performance managing doctors and nurses. Because these organizations need educating that just because somebody admits to having mental health issues, it doesn't necessarily mean that they lose their license immediately, which used to happen in the past. There are cases when they need to lose their license, of course, but it led to a lower number of people presenting because they were so scared that they would get into difficulty. So to end up today, I just want to concentrate a little bit on solutions around the contributing factors. So I already mentioned issues to do with managing burnout better. In other words, managing time for clinicians better, ideally giving them more time for consultations. Whenever that's possible, it isn't always possible. But also introducing clinical decision support systems for them to use so they don't end up in a situation where they're worrying whether they've actually treated somebody in the right way. They're worried if they forgot about a pathway that they should use. And it is possible for us to deploy new digital solutions, new electronic medical records, in a way which actually assists clinicians rather than interferes with the clinical flow. Sadly, in the past, very few people actually took this into consideration in new deployments. Nowadays, partly because of burnout, people have learned and they go through a program of introducing new electronic medical records. Not they just introduce them overnight, which is what happened in the past. Clearly, we need human resources support. Of course, we do. And we need better resources support to manage these conditions. But probably what's really, really the most important is actually managing the transition to a less medical model. Because with the aging populations, which we have globally, we need to start introducing better, a more systematic self-management of individuals to actually lessen the load on the medical and nursing professionals, because they're never going to catch up otherwise, even if we manage to fix the workforce, which we're not going to manage in the short or medium term. So a transition to a less medical model, ensuring we train people in behavioral health, we train people who don't necessarily need to be medical professionals to assist people with non-communicable diseases. We will better manage the workload of the workforce we have, and that in itself will assist in mental health management. We need to really understand the effect of the pandemic we've had, because the pandemic has a very long tail. And by that, I mean, because we have undertreated conditions during that pandemic, clearly now they're coming and accelerating their deterioration more than we otherwise would expect. That in itself is a significant problem. And finally, reviewing our management in general of non-communicable disease, again, with putting the onus on the individual to manage themselves. These are going to be the only solutions. So to conclude, really, I think we need to move from where we were on the left, which is really with mental health being the elephant in the room, to where we could be on the right, where the elephant is in the room, but at least we know it's in the room and we acknowledge it's in the room. Thank you for your attention.
Muchísimas gracias, doctora Alessi, por su
Thank you very much, Dr. Alessi, for your excellent presentation. It is very important to always take into consideration of mental health and the problems of mental health, and that we should have a deep impact on performance as not only at work, but also in school, but also and at work, and the stigma that comes with discrimination comes with the professional, health professional, impedes them from sharing the issues they may have, and have anxiety and other problems, which can limit the development of their work and having a full life, a calm life, and harmonious life at the workplace, and to provide service of quality. That is why, and that's why it's very important as you have said, that employers and that administrators recognize the importance of training all their personnel to be prepared to identify things, and Peru has been one of them. And perhaps having these support groups that they can share this information, and so that they can have a work environment that is more healthy and with greater institutional support. Very, very important. I believe that is very important what you have said, but it was important to remark that. Without further ado, for the moment, I now wish to present Dr. Dimitar Georgiev, to whom we give the warmest welcome. He's a physician with a lot of experience. He's a specialist in obstetrics and gynecology. He has worked a lot in these specialties. Just a moment. Above all, he worked a lot of this up until 2006, and he has successfully performed more than 5,000 deliveries. His deep understanding of patient care goes beyond the physical, as he recognizes the critical importance of mental health, especially in areas such as burnout and maternal mental health during pregnancy. Driven by this awareness, he has expanded his expertise to life sciences sectors, where he actively invests in and supports innovative solutions to mental health challenges. As part of his commitment to improving global mental health outcomes, he has co-founded 2 startups focused on digital therapeutics with the objective of providing accessible, affordable, evidence-based treatment to those in need. Aware of the global mental health crisis, which is characterized by limited access to quality care, he leverages technology to address this pressing issue, advocating for scalable solutions that bridge the gap in mental health care delivery. It is for us a pleasure to have Dr. Georgiev, to whom we provide a welcome. Please proceed with your presentation.
Muchas
Your
gracias.
microphone.
Buenas noches.
Thank you. Good afternoon from Bulgaria. It is 7:40 p.m. I speak a little bit of Spanish.
Should I upload my presentation, Bogi, or you present? All right.
No, si está habilitado para hacer su propia presentación.
Oh, you have granted permission to present.
Do you
Yes.
see my screen or no?
Se ve perfecto.
Yes, it's not in presentation mode. Yeah, now, yes. Good.
Yeah, okay. So thank you very much for inviting me. I'm really delighted. Latin America is the continent which I have visited at least 20 times, and I hope to visit it again and again and again, because I adore so much the culture, the language, the food, and the people. And I hope to be able to contribute at least a little bit for a better understanding of 2 diseases which are mental and which affect workforce. One is the burnout. Thank you, Dr. Alessi, for opening the door so nicely. And the second one is postpartum depression, which is actually affecting workforce in an indirect way. Few details about me. I am 62 years old, have been working extensively as obstetrician. Dr. Lagos explained very well my biography, but in a way, I changed my life and decided to go and scale my knowledge and help more and more people with scalable solutions. And I will speak tonight about 2 opportunities to help people with mental disease, especially for diseases which are interdisciplinary, which are not
very well understood by the society, and can be said that they are also neglected in a way. The mental health in general is a huge problem, and it's a problem from both occupational and human perspective. As Dr. Alessi mentioned, there are several factors besides COVID, of course. We have the 2 wars in Europe, which are really pushing us down. There is poverty in the world, which cannot be overcome so easily. And of course, the social media, which are exaggerating more and more the problem with mental health. And everyone who reads about people who have mental problems is asking himself or herself, do I don't have the same problem? Probably yes. The solutions which are offered are, I would say, old-fashioned, and they are old-fashioned because they are dealing with tools which are old, which are not accepted, especially by the Generation Z, and which are not scalable. My mother was an occupational physician, and I have asked her several times while she was alive, did you experience once a patient with a burnout? She said, in my career 20 years ago, this was not known at all, that there was not such a problem. We had other problems, poisoning and so on, but not mental problems in the work. Probably there were problems, but they were not acknowledged, they were not described, and they were not treated, of course. Also, these old-fashioned solutions are expensive. I can say that they are also time-consuming, and the outcome is not sure. There are also, for the modern medicine, very few biomarkers which can be used for diagnose and optimize the treatment. This is why I think that probably we need to look for better solutions which are digital, which are scalable, which are equitable and cheap, and which can help on a scalable way to much more people than, let's say, the old mode. I will speak today about burnout and postpartum depression, and for both the entities or diseases, because burnout is not a typical disease. I will explain why. There is no effective treatment. There are problems which are considered interdisciplinary, and thus there is no specific branch of the medicine who is treating neither burnout nor postpartum depression. The burnout is something which is known, I think, for already 50 years, but the problem is getting bigger and bigger and bigger, and it's not an elephant in the room, it's probably a mastodon in the room or a dinosaur T-Rex in the room, but it is not classified as a disease, it is classified as a syndrome. And this creates also problems for medical documentation, for paid sick leave, and so on. Burnout in Europe is one of the biggest contributors for sick leave, and also is considered as fairly untreatable. So patients who have burnout or who think that they have burnout, they are not going with pleasure to psychologist treatment. They are not compliant with the therapy. They don't get any pills, of course, because there is no pill for the burnout. There is no uniform treatment protocol. Unfortunately, psychologists are treating burnout in different ways. And also, from time to time, patients with burnout go to psychiatrists, to coaches, to life therapists, which I think have no clue how to treat burnout. Additionally, what I think it's important to be said is that burnout, in a way, impairs not the person alone, but the entire family, the entire group of friends, because if you are not happy with your job and with your life, you cannot please your family, you cannot please your friends, and you cannot please anyone. So burnout is a problem, a disease, or a syndrome, which is really bad. And I hope that there will be enough solutions which can help to people with burnout, because those are young people who are suffering, they are stigmatized, they don't contribute to the society, well, they have really big pain. Considering all these parts of the puzzle, we decided to create a digital therapy. Not a digital therapy per se, but first a self-help app, which is considering patients or persons affected with mild to moderate burnout. When the app, it's an app which is available in both stores, in Google and in Android. When the app is downloaded, patients are stratified in 3 different treatment pathways. And in fact, if the treatment is successful, there are 2 or 3 questionnaires during the 12-week course of the therapy. If the treatment is successful, we say thank you, goodbye. But if we see that there is a problem, we advise the patients to visit a psychologist or a psychiatrist. We have seen this as an opportunity. The app is released globally, but unfortunately, we were not able to capitalize the company well. So now we are restructuring it a little bit, and we hope to release it soon. But the first feedbacks from patients and from customers were very, very good indeed. The other entity which I would like to address today is the postpartum depression. The postpartum depression is a severe problem for women who deliver their children and also for the entire family. The frequency is considered to be 10% of all pregnancies. And even there are publications that this percentage is getting higher and higher. And some experts say that every 5th delivery ends with a depressive disorder. The problem here is that when you have a child, you should be happy about this. You should be flying with your mood, and this is not the case. And usually such conditions are not recognized, they are not reported, and the doctors avoid to treat because they are afraid to treat women with postpartum depression. Why? Because if you consider this as a real depression, you need to give antidepressants. And if you give antidepressants, you should stop breastfeeding. That's not okay. My teacher in endocrinology was happy to say that postpartum women should avoid 3 topics starting with P: psychologist, psychiatrist, and progesterone. So he was considering that postpartum depression should be treated by obstetricians, which is not easy because this is not in our specialty. And the occupational problem with postpartum depression is that families who are affected, because this affects not only the mother, but also the father, do not return soon to work. They stay at home, they are treated, and it affects, in a way, the productivity of the family. Seeing that postpartum depression is growing, unfortunately, and that the treatment is so difficult and not sustainable and expensive, we created also an app, which is called Mom Sanity. It's a self-help app. We used, because it's the same team, the scaffold of DigiBurn. It's a 12-week course with a relatively low cost. I can say extremely low cost. It is not live yet. We need to finalize few details, but I think very soon we can release it. It will not be released as a global app. It will be released first in Europe, and I think early next year also in Latin America. And we hope to contribute to the global understanding of postpartum depression, and at least on a small subset of women with postpartum depression to be able to help. The initial aim for the two projects was to develop them as digital therapies. Why? Because we think that digital therapies are something which are scalable, affordable, equitable, and also extremely easy to be used because you have practically the therapy in your phone. It's universal. You see, I speak English, you hear Spanish, so now translation is easy, it's practical, and I hope even effective. The trouble with digital therapies is that it's not a trouble, but it's something which is a hurdle. They are very regulated. And they are regulated because people who develop digital therapies expect that their solutions are reimbursed, at least in countries with a social healthcare system. And in order to go for this, you need to do an expensive clinical trial, to find a workforce, to convince doctors to prescribe the digital therapies, which is not easy. So this is why we go in direction digital therapies, but with small steps, because we think that we need to improve our products and then decide to do clinical trials and go for reimbursement. What is the general understanding of our solutions which we have for burnout and postpartum depression? It's good that they are affordable with a low cost. It's, once again, they are very convenient for the patient because you have practically the therapy in your phone. You don't need to go to make an appointment to go to a psychiatrist or psychologist, to wait to come back and to pay. They are practical. They can be used in mild cases without any risk, even if they work as placebo. They are not affecting your performance in your profession, and they are not affecting the attitude of the employers because not few of the patients with postpartum depression and burnout hide their problem. They don't admit the problem in their job, and understandably, they cannot go during office hours for treatment. Also, we think that such solutions are generating very fast a good database for patients with the problem, which can be analyzed, and then probably a background for a better decisions. Once again, it's difficult to get a designation for digital therapy and for reimbursement, and unfortunately, in both diseases, and also in the digital solutions, biomarkers, which are vital for personalization, cannot be applied at this moment. Thank you very much once again for inviting me, and I hope that my presentation was interesting, and I also hope that I will get some questions. Thank you very much.
Muchísimas gracias, estimado doctor Georgiev. Realmente los dos temas abordados son.
Thank you, esteemed Dr. Georgiev. Truly, these are something that is very important for many reasons, for professionals and to anybody who, since very young, they have a different chip set, that we have to be good workers, that we have to do this. We don't have to get tired. We always have to be alert. You always have to be on call. And also, women since very young, they tell that you have to be a happy mother, that being a mother is a happy moment, and you have to be happy for lots of happiness. And they all have this problem that if you don't answer to this, you don't find a solution, you will be stigmatized. You're not a good worker, you're always tired, you're not a good mother, you're not going to learn anything. And that is why it is very important what you have mentioned regarding communication. Every time this is more important, even more important to have this information, to know more about mental health. I know that everybody, each and every one of us, is in will have some sort of problem in our mental health, and that is not and also to be empathetic to what you're doing with people. I believe that this is very important, and you can be to have all your team, to have everything be ready for everybody, and that they can provide the support at the moment in which they need it, both the employee and the mother. So we will take this into account and we'll always keep them in mind. Now, after thanking you two for presenters, we're now going to go to the dialogue with the authorities and with you. And for this, we wish to thank the presence of two people, of two authorities of the Ministries of Health of Colombia and Ecuador, who have accepted graciously to accompany us in this exchange of ideas. We have now psychologist Adriana Arevalo, specialist in occupational psychology and organizational psychology. She is Technical Secretary of the National Commission of Security and Health at Work, Office of the Transportation Sector of the Ministry of Labor in Colombia. We also have Javier Cárdenas, clinical psychologist, doctor in mental health and master's in public health, specialist of the Public Ministry of Health in Ecuador, responsible for the national policy for mental health. I am going to ask first Adriana, then Javier, and then pass to let them to provide us with their experiences of what they have known and also the information of what they may wish to share. Please proceed.
Hola, buenos días. ¿Me escuchan ahí?
Perfecto, Adriana.
You hear me? Yes,
Gracias.
perfect.
Bueno, buenos días. Reciban un cordial saludo.
Well, thank you. You have. We are very proud of the Ministry of Health and pleased that we find each other here with people who have been working on everything that belongs to health in such a disciplined manner, and who also think about employees, their well-being, and whose performance is going to be so important. And if they're happy and they have proper conditions, and furthermore, if we as employers, we take care of this mental health, we're going to find people who are happy and they're going to be better. So my thanks from the part of the Ministry of Health. My name is Patricia Arevalo Beltran. I'm a psychology in the workplace, and my salutations from the Directorate of Labor Affairs and the Coordinator of Promotion Work, Dr. Jorge Enrique Barra. Well, I wanted to tell you a bit more about what we have been doing here in Colombia since many years ago, since 2008, in which they have this resolution 2646, in which they establish the responsibilities for the prevention and intervention and monitoring of risks, of the risk factors that can be found in the workplace, and the determination that of the origin of pathologies caused by stress at the work level. What do we seek to do with this evaluation? What we seek to do is to identify risk factors and to transform them into protective factors. This evaluation contains the following elements. Contains an intra-labor evaluation, extra-labor evaluation, and a data sheet of information that will allow us to evaluate stress. Intra-labor, what dimension does it have and what does it evaluate? As to evaluate the labor, work demands, control over work, and rewards. When it comes to risk factors that we have, we wish to see how the company is behaving with these people, and also to provide and to generate an action plan or plan of action. These are done to all people, both plant as well as personnel that has been contracted in the different institutions. And this is done everywhere. So we also have the tools that allow us to evaluate how their life goes outside of the workplace. For example, how are these family relations, interpersonal relations, how are the characteristics of the work, how is this communication relation, interpersonal relations. We also have the general data information that will allow us to be able to have a social demographic profile of this population. And finally, we have the instrument that will allow us to verify how the stress levels of people are going. What do we seek with this? Mainly that we seek to have is to verify what are these risk factors. And once we have them identified, we should be able to generate action. These evaluations of psychosocial risk are performed by a licensed professional who specializes in health at the workplace. All this information is given by the law, which is the code of law 1090, and all this information is information that Publica Pedagogy talks about confidentiality. And in 2022, we have the resolution 1774, which adopts protocols that were providing in 2015. These protocols of intervention can be used by companies. And these protocols are given in the following distribution. We have those of general distributions, which is of different factors, and the prevention of these effects. We also have the protocols per economic sector. These protocols per economic sector, we have public administration, we have defense, education, health, and transportation. And there you will find tools that will allow companies to be able to mitigate these risk factors according to the diagnosis that they have or the level of risk that they can find. And finally, we have some protocols for attention to effects, just tools that are going to be used to be able to work within companies on stress, post-traumatic stress, burnout, grief, and harassment. These are the tools that we currently have in Colombia. And from the Minister of Health and Minister of Health, we are working also the project of mental health with the objective of providing our workers, having account the law 1717, we talk about the care that we must provide to people that provide their services to hospitals and systems. We also wish to share that at this moment, thinking in our works and thinking in workplace stress that can be created and how we can begin to mitigate it. Evaluation of psychosocial risk, which is an evaluation that can only be done or performed or can only be applied in person according to the requirements of the Resolution 2646, but now at the request of many companies, of which are this in-person presentation is difficult, we are creating this means of being able to evaluating this risk confusing. This instrument can be used in all companies virtually and it will have no cost. All companies can use them, but to be able to use them, we are collecting information from psychologists at the level of Colombia that have the license and that are specialized psychologists, because there's one of the requirements to be able to work in the evaluation due to the issue of confidentiality. So, at this moment, we are working on different tests to be able to achieve that the next year, or at the end of next year, we're not sure yet, we can perform the launch of this information system. And finally, we wish to tell you that on behalf of the Ministry of Work, we have done various activities and many agreements with the organization, Inter-American Association, which was held in which last year they provided many solutions for mental health and to psychosocial issues directed to informal workers. The evaluation that was made for the psychosocials are directed to formal workers, and these new instruments this can be verified by for everything, and for this event we chose the 6 cities that have the most, in which the cities that have the highest level of informality, in which we talk about self-help, promotion of mental health, reinforcement of abilities and capabilities, social emotional, such as resolution of conflict, making of decisions, conception of interpersonal relations that are positive, support assertive communication, with the objective of that the informal worker can know that he has the support of the Ministry of Labor and the various institutions, not only to improve his labor conditions, but also to his mental conditions when it comes to the reinforcement and work that they do on their day-to-day activities and at their home. And that is important too. The evaluation of risk is also made to generate action plans to be able to provide support to these people when it comes to issues of double work in the case of women who have their workplace activities, but also they have to help for their activities at home, help them with the homework, etc. So it is conceived to be able to help them in management of their time. And to conclude, we wish to tell you that this year we are doing a new agreement with the Ibero-American organization, in which we are going to have new protocols of stress, which are going to be updated every 4 years. It is time to update it now. We have the objective that professionals can evaluate and can help workers. Second, we are preparing a protocol for providing tools to people that are working in hospitals, especially in urgent care, emergency rooms, to see how we can improve conditions to them, be an evaluation to get to know what are those risk factors. And finally, we are having this instrument to evaluate the armed forces here in Colombia due to Law 100, Ley 100. These evaluations that I just named are not on charge of the police or the military. As such, what we want is to be able to have an evaluation, to be able to evaluate them, because they are professions of high risk, as they are exposed to various conditions, both at the intra-labor as well as stress. So that is what we wanted to tell you from Colombia, the work that we have developed, and to thank you to the people who have presented, because really the work that you do is admirable. And thank you for the space, Dr. Gloria and Doctor.
Muchísimas gracias, querida Adriana, por tu
Thank you, esteemed
participación.
Adriana, for your participation.
Voy a cederle la palabra a
I'm now
Javier
going to give the podium to Javier Cárdenas,
Si acaso hubiesen algunas preguntas para
and then
él,
should there be any
iniciaremos
questions,
el diálogo.
then we will begin this dialogue.
Preguntas que ya nos están llegando del público.
We have some questions that are coming on the part of the audience. Please, now provide your feedback, and then we can provide some information. Yes, thank you. Good afternoon. First of all, I wish to thank you for the invitation to this webinar. As Gloria has mentioned, I'm Javier Cárdenas, and I work with the Ministry of Public Health. And of the presentations that the two experts have made, I retain one idea from each. For Dr. Alessi, regarding stigma, excuse me, can you hear me? He said regarding stigma and regarding people that can be going for mental health problems. And when it comes to the everything else, this can be seen in two ways, as we have seen. One, when it comes to permanence of people in the workplace, and also when it comes to the entry to our working workplace. I believe that is important, as the doctor has stated in his presentation, given that even though it is true that it is important to generate some strategies that can provide us an idea about the magnitude of the problem, no less true that we have this issue that requires some time and other strategies in which many parts of the government can participate. Another point, Dr. Les, which I believe was important, is sensibilization, which I believe goes hand in hand with stigma. One of the interventions that they spoke with the gave the girl situation was the about sensibilization and awareness. However, in some cases, the presence of some symptoms which can lead to any diagnosis of any symptoms cannot lead to also to some medicines on the part of the people, but also of the main colleagues of the worker, and this can create some problems in the permanence of the person onto the workplace. And Dr. Dimitar called to my attention the fact that, and I'm in agreement that when it comes to protocols to see this, are essentially of the people who have been identified as having some sort of mental health problem. This is something that is fundamental. Our problems are segmented, meaning that they have various providers of health, from Social Security, including workers and armed forces, but also the Ministry of Public Health, which has the responsibility of providing coverage to the insured population, which we can see in this private health systems. Now, this can generate some difficulties when it comes to the way in which they are treated, even though it is true that these are important when it comes to the attention of insured. This, in certain moments, they may not have the capability to be able to answer the various characteristics of the pathologies present in employees, and they have to be sent to other subsystems. In this case, those can be of the public ministry as well as the private sector. This is complemented by what the experts have said, and in the case of Ecuador, currently we are in a process of two policies. The first of health security in the workplace, and the one of the organic law of mental health. And this second one, in which I work, we have seen that we're in the process of diagnosis. We have seen certain interesting elements for mental health that obey the subjects relating to this, but also to these social problems. First is instability, mental and work instability, and they will have to do with the elements of developments that are given in the processes, which are part of the productive sectors and of employees, and that provides a lot of uncertainty when it comes to the way in which they're going to be working. This affects their mental health. Reason to this, we see that we are in the process of formulating some punctual issues or policy, and we have based ourselves on certain points which are fundamental, in which we can see a lot of evidence, which are the main issues for mental health in the workplace. One is increase of mental health in employees. They want into providing aid to these people who may find themselves in some problems, should they present any problem of mental health. The other one is to provide aid to people who have some mental health problems and issues, to have them be more equitable and that they don't have an additional charge or load in the workplace. And the second one is to reintegrate people that may have some problems in the workplace. The reason for this is that we have started work in the policy and work in the creation of mental health that we have since January 2014, which is Article 24 of the Promotion of Health disposes for the authority, along with all work authorities, to implement plans and programs and projects in order to increase the issues that will help the well-being of people and to increase the mental health of everybody. These that we have provided in the country that have given us a result, as an initial result, the creation of indicators that are focused on these points which I have also mentioned, and having as a goal that we reach a period that goes into 2024 until 2030 to provide coverage to 90% of workplaces that can meet the various certificate, which is called Actívate y Vive, or activate yourself and live, which dictates to these workplaces that they comply with the certificates and various parameters that among them the ones that I have mentioned already. For the moment, and due to time constraints, that is what we have. That's what we can state regarding the advancements that we have had. When it comes to legislation and laws and policy that we are developing, and also with the plan that we're going to provide for these next 2 months in the country. However, we also wish to state that there is some information as well in which we have been able to provide information to the purposes, mostly in the implementation of programs of reduction of social risks, and also in identifying certain problems that are present in employees that can be treated. But in policy, what we want to do is we wish to increase the points which I mentioned. That is all for now. Thank you. Thank you very much, Javier, for your presentation. And now I'm going to open up the dialogue for you as well as Dimitar. If you have now any questions or any comments you wish to ask for your colleagues in Colombia, I open up the mic.
Well, thank you. I have a question actually for Mrs. Arevalo. add also for Senor Cardenas. If we want to launch our apps in Ecuador and Colombia, how should we proceed? Should we go directly to the audience in the app stores, or should we contact the health authorities first for any permission or any form of agreement? What would be the best way to go?
Perdón, solo un minuto. Adriana no está entendiendo porque no habla inglés y no está en el canal de español. Adriana,
My
querida,
apologies. Adriana was not in the Spanish channel, so I'm going to indicate her to go to the Spanish channel. And they're indicating her to select the appropriate interpretation option, as we have both channels available. It's on the lower right-hand corner.
No, está en una redondelita tipo
It is in a globe-style icon. Let me know if you can find it. You found it. If not, I will comment what Dimitra asked. What he's asking is, should he want to have his app reach Colombia and Ecuador? How can he do? Should he go directly to US providers, or what is the road to go in order to share these tools that he wishes to share with us? That is the question. Please, Javier, and then we'll give the to Adrian. Yes, unfortunately, the policies that the other country is developing on health and well-being, mental health is part of the Ministry of Public Health, and this means that the channel would be the sanitary authorization, Autoridad Sanitaria, of the ministry, and it is very important to state this. I believe it's a very important opportunity, as at least in the public health policy, there is an access of virtual assistance, which can be very helpful, and which can be very helpful. Thank you very much, Adriana. How could you do with Ecuador, Colombia, in the case that they wish to create this tool that was presented by Dimitar, which is for having the providers? Well, first of all, my apologies. I've had some problems with my computer, and I could not go into the part in which when you were asking the question, but yes, of course, we would be very happy to get to know your tool and to do an exchange of information. That would be very important for us to present to you what are the advances that we have had in Colombia, to show you the protocols, the tools, as well as to get to know the work that you have been developing, because I believe that it is very important. And I believe that to be able to articulate between countries, I believe that is very important, as we can complement our strategies to be able to train our employees and our workers. Something that that Dr. Cardenas was stating seemed to be very important to me, which is management of mental health, to be able to check loads, to do this. It is very important because many times, according to different capabilities and capacities of people, we do not notice, and we give more tasks to somebody without having this appropriate distribution. In the evaluations that I have been provided, my apologies, because you let me know if I need to stop, because once I get the microphone, I never stop. In our evaluations, what we try to do is not only for the evaluation be for the employee, it is interdisciplinary work for us to have a proper working and For it to work in a company, it has to be done within the employees and then downwards. Here in Colombia, we have the resolution 1072 and 032 to talk about the system of management at the workplace. With these tools, we are also trying to reduce accidents within companies. And this is articulated and validated with an evaluation of psychosocial risk and evaluation of implementation of the pillars that are of routes at the for road safety, which for transportation companies is very important, thinking about the well-being of the employees, not only workers but also their mental well-being. Thank you, Adriana. Dear Adriana, I do not know if there is any further questions. Please proceed.
Thank you very much for allowing me to ask a question, and thank you to both the delegates for their presentations, which I really enjoyed. I'm coming back to this subject of burnout because in the United Kingdom, which is where I am at the moment, we are in crisis with a medical profession which is really, really in significant difficulty, with a nursing profession where we can't fill the posts. And if there's one lesson, I think, which it would be worth considering, just to make sure we do remember that what happens in one country often happens in others. The same is happening in the Scandinavian countries. The same is happening all over Europe, actually, at the moment. It's that unless we introduce systems to actually better manage our workforce, we're going to be in even more trouble. This is as well as, of course, assisting individuals with self-care and everything else I talked about. But having dedicated systems for workforce is extremely important, which are anonymous, which are confidential, which are dedicated, because unless we do, we already have problems with workforce. They're going to accelerate, and it really is a plea to you both to really take this. I know you do take it seriously from your presentations, but clearly, I wouldn't want anybody to be in a situation as bad as what I'm seeing in parts of Europe at the moment. I don't think you're quite there yet. Thank God you're not. Don't ever get there.
Muchas gracias. No sé si tienen algún comentario, algo, Javier.
Thank you. I do not know if anybody else has any questions. Otherwise, we can provide some more questions. Well, I will say that we have many, many questions. We have many people who are listening to us, and I am going to break a bit the order, and I'm going to thank everybody who is accompanying us today, especially the officers, officials of the Ministry of Health, academia, social organizations, and the public-private organizations of the following countries. We have from Argentina, Bolivia, Brazil, Bulgaria, Chile, Colombia, Ecuador, Honduras, Mexico, Panama, Paraguay, Peru, United Kingdom, and Venezuela. Having said that, I'm going to begin now to share some of the questions. Here for Dr. Alessi, how do you believe that in the increasing prevalence of mental health in the younger generations, how do you think it is affecting the global charge of global burden of illness, and what can you do to alleviate this? Please proceed, Dr. Alessi.
Thank you for the question, and this is a question which I think we're all asking in terms of exactly how we can manage what is becoming similar to an, I'm going to use the word epidemic of mental illness amongst young people. Clearly, we're rethinking the way we deliver services at the moment. We all know that the earlier you intervene in mental health, the more likely it is you're going to get a better resolution, and you're going to get a cure, or you're going to get better management, rather than you wait until the condition deteriorates to such a degree. So we're actively investigating opportunities for digital interventions is particularly useful, because of course it widens the availability of child and adolescent mental health services, which have always been very difficult to access in all countries in the world. So that is particularly important. And also developing blended approaches, because the blended approaches would allow the few mental health professionals that specialize in these areas to be able to extend their reach even further. I believe these are the only approaches that would work on the provision side. But of course, we need to also try to ensure we introduce systems which reduce the levels of prevention is always better, of mental health amongst young people. And clearly there are issues around cyber hygiene, issues around the use of applications, issues around the use of smartphones and social media, which countries are experimenting with to try to manage this epidemic. Because unless we do, it could well overwhelm us. I think you're right. I don't have all the answers. I wish I did. All we can do is learn from each other.
Muchísimas gracias, acá peleando con el micrófono también.
Thank you. Sorry, I was fighting with my microphone. But anyways, thank you very much for your response. I have a question for Dimitar. How can postpartum depression affect the dynamic of depression? And what is the role of the father in this context, considering the reticence of Generation Z to address mental health problems? Please, Doctor.
Well, that's a nice question. And as I mentioned in my short presentation, postpartum depression affects everyone in the family, the mother, the father, and the child, unfortunately. Because what I understood from your comment on my presentation, at that time I haven't switched to English, that's the best time in the life of a woman to be mother. So everybody is affected. The father is affected, and his role is very important actually, because he can be actually the person, the main pillar in the family at that time, and he must be the main pillar in the family at that time, because postpartum depression cannot be treated well with drugs, with tablets. It should be holistic treatment in the family, and the role of the father is very important. I hope that I answered properly to your question.
Sí, Dimitar, nos preguntan también qué estrategias, qué estrategias.
Sorry, thank you, Dimitar. What strategies do you know that can improve communication and treatment with Generation Z specifically?
Well, apparently the Generation Z is the main topic of the event this evening, and this might be right. My personal understanding is that the communication with this generation is difficult. And we, being from another generation, have troubles to communicate with them the important parts of the life. So I think that the Generation Z lives in another world. They have other topics in the life. And fortunately, there are few strategies which are working. And in a way, the digital way to communicate with them is the better one, because I see colleagues or my employees who are from this generation, they are not communicating verbally. There is no verbal communication. They write emails or text messages, they look in their phones, and that's it. So we have to accommodate, because the problem with the postpartum depression is already there. And I'm not sure that the medical professionals know the right way to communicate with them about this problem and also about other problems related to mental health. I'm not speaking about depression. I'm not speaking about other conditions, classical depression. I speak about burnout and postpartum depression. And the main channel, according to my opinion, should be the digital way, because they don't attend sessions with psychologists. They don't go to open meetings where you can discuss. They sit at home, they write their messages, they look at their phone, which is poisonous, but that's the reality. That's it.
Can I just comment on this a little bit?
Please go ahead.
Because this is a really interesting subject when we come to Gen Zs. And we've had experience of it in Public Health England. I was senior advisor to Public Health England, and particularly during the pandemic, the early pandemic, and also in attempts around screening where we tried to access Gen Zs. We failed in the beginning because we didn't quite understand that the language we were speaking to them with was the wrong language. As you quite rightly said, Dimitri, if we go to ask people who are my age to actually speak to them, experts are the wrong sorts of people to speak to them. But the moment we found champions amongst them to speak to them, the moment we channeled social media influencers to actually give our messages, everything changed. Then we access this population better. I think we need to rethink the way we communicate and use them to communicate with them.
Yeah.
And we haven't done enough of that, but we're learning. We're learning.
And the problem is how to convince the influencers to speak right, because I know influencers who speak in the wrong way. And
I think that's possible because there's only few of them you really need to actually get on your side. Then it's possible for us to do that. It's train the trainers. That's the sort of approach I would suggest.
Yeah, completely agree.
Muchísimas gracias, realmente totalmente de acuerdo con lo propuesto.
Thank you, and I'm completely in agreement with what has been proposed. I have a question for Dr. Alessi. In relation with the workload and work stress, what specific strategies would you recommend to implement therapeutic groups, especially due to time management in the workplace that this would take? Please, Dr. Alessi.
Thank you. The perennial question, of course, and really there are many examples which I can talk about, which have been used in different countries to try to address this problem. But there's something common in all of them, and it's a better management of the diaries and appointment diaries of the individuals. Trying to protect a little bit of time during the day to ensure there is enough time to depressurize, particularly, say, in the middle of the morning, a small protected 20 minutes, 15 minutes to give people time to catch up, to give people time to catch their breath, to give people time to have a cup of coffee, and to give people time to have a chat with somebody else, a colleague in particular. Remember, mental health, healthcare professionals are now working to a great degree in a hybrid fashion. They're doing face-to-face consultations, they're doing telemedicine in different formulations. And I think we underestimate the level of stress associated with using some of these modalities, because of course, as a clinician, I would like nothing better than to treat somebody who's actually in front of me. I'd like nothing better than to have enough time to really have a conversation and get to know someone and get to know about more than what they're talking to me about. But often I'm in a situation where I'm forced to either use a telephone, and I can't see the body language I need to see, or to have a video conference, and I can only see sort of 2 dimensions. I can't really see the important things, the non-verbal communications, as well as I could. So it's a different way of working. So the answers are protected time whenever possible, training clinicians, because video consultations, telemedicine is not a translocation of a face-to-face. You need a different style. You need a different approach. And we can teach clinicians to do that. It's possible. I managed quite a few courses over the years assisting clinicians to actually understand they have to do things in a slightly different way to get the best out of their patients. This helps give them the confidence to decrease the stress. But of course, there is no simple answer. These are just some tactics.
If I may say something, do you permit? So the other profession, Senora Lagos. So the other profession which is deeply affected by burnout is the profession of the teachers. And they have also a lot of troubles with communicating with the generation which they are teaching, because there is a big difference between what they can teach and what the generation understands, and what are the end point tasks for the teachers and for the generation. So I would say also less expectations, because if you have too high expectations, it's very difficult to meet them.
Tenemos una pregunta más para
We have
completar
one more question to complement this issue that we are commenting upon. Same with the appearance of other applications, what do you see is the future of these digital therapies, and what measures are being taken to evaluate and mitigate the same risks associated with these mechanisms? Please, Dimitar.
So who are you asking? Sorry.
No, go ahead.
Oh, okay.
A Dimitar.
To Dimitar.
Sorry.
For me, you mean the risks
Pero
for the
no,
digital?
luego, por favor, si lo considera.
But afterwards, if you also wish to answer for Alessi, you can also answer afterwards.
Thank you.
I'm just saying that this is the question to Dr. Dimitar, but that doesn't mean that you can complement it as well afterwards. Please, Dimitar, proceed.
Thank you. Actually, the risks with the digital therapies are overestimation of the expectations, less efficacy, difficult reimbursement, and difficult penetration in the society. Because in order to make a real and good digital therapy, you need to go through a long and expensive pathway, and this is not always possible. So now there is a hype in Europe and also the United States for the digital therapies, but how far this will be successful, I'm not sure. I still have some concerns. I have seen a lot of digital therapy, not a lot, but some digital therapies in Europe who have been approved for reimbursement and who have been dying out because they cannot reach their target population. And for the future, I hope there will be more digital biomarkers which will further personalize the digital therapies and give them better chance, because now is what we have already trying to avoid in the general medicine, one size fits all, one digital therapy for every patient. We need more and more personalization. For this, we need more digital biomarkers, more wearables, more data, more information, much more experience, probably 10 years, and then we will know.
If I may, I'd like to comment. I agree completely with my colleague, by the way, and all the points.
Mi querido doctor Alessi, adelante, por favor.
Oh, please go ahead, Dr. Alessi.
all the points I completely agree with. I just want to comment on one or two things. One is the licensing issue regarding digital interventions. I think it's really important we take that seriously. There have been some attempts in the United States. They're going down a good path, I think. In Europe, in bits, we're going down a good path, not completely, because we're in some difficulty around the whole licensing process. But on the whole, we need to take this much more seriously. So licensing is important because, of course, we need quality products, because not all digital interventions are the same. So that's one issue. And the second issue is around the financial metrics and reimbursement. I'll tell you a very, very ridiculous story around why a lot of digital interventions are failing. In one jurisdiction in particular, the digital provider was only paid when an individual not only started the course, but finished the course. Now that makes sort of sense, doesn't it? You're a healthcare provider, you're a government, you want to pay for services that people receive. But it's quite amusing when you consider the way we reimburse drugs. How often do people complete a course of antibiotics? Are we proposing that we only actually reimburse a drug company when somebody completes a course of antibiotics? They'll all go bankrupt. Because so few people do. So we have this double standard where with digital, we want to ensure that things are absolutely perfect. But with chemical treatments, oh no, it doesn't matter. As long as they get the medication, they can then put it in the drawer or throw it away. It doesn't matter. I don't think this is quite reasonable. We need to think this through a little bit better, because in digital interventions lie the future of healthcare. We have to get this right, because this is the only way we're going to treat the maximum number of people, introduce equity, and introduce what we're dreaming of in terms of having health systems which are available to everybody. This is our only hope. We've got to get it right.
Y en esa línea, estimado
Along those lines, esteemed Dr. Alessi, what are the main barriers that you can identify to normalize the care of mental health in healthcare professionals?
Oh, this is a very difficult question to answer. There are so many barriers, and stigma, of course, is so important. Now, if you're talking about the general population, of course, the first thing anybody would tell you is the digital divide. The divide between the people who can access digital tools and the people who can't. And of course, the age issue, the older people, etc. But the barriers are enormous, but they're mainly associated with stigma. I think if we get our heads and start treating mental illness the same way we treat cardiovascular disease, we somehow will find it easier to actually introduce these systems. And I think this is the way we need to go. And we are seeing the start of that, where people are talking about these conditions in the same way. We're moving away from condition by condition to considering them all together in a personalized way and delivering them in a personalized way. I think that's the only solution, but we know what the barriers are. We've lived through them all our lives.
Gracias. No sé si hay algún comentario por parte de...
Thank you. I do not know if there's any comments on the part of Dimitar. If there are none,
Yeah.
please go ahead.
I just wanted to say that I have seen the long way which the pharma industry went since 1990s, and there are still a lot of hurdles also there. So I think that the digital therapeutics are now there where the pharma industry was in 1990s. So there is a long way to go. Probably the same hurdles, probably different, but there will be a lot.
Muchísimas gracias.
Thank you very much.
Tengo dos preguntas finales.
I have two questions.
A fines de octubre,
At the end of October, the WHO in Europe has launched this survey on mental health of personnel that's in charge of healthcare. What variables do you consider to be of greater relevance for the collection and analysis of data? This is a question for both of you.
Should I start?
Please do.
So I would say every wearable which collects reasonable data should be considered as an opportunity. I am wearing, for example, the Oura Ring for 2 years already. I'm very happy. It started with the sleep analysis. Now Oura is doing a lot of things, inclusive they are measuring temperature for ovulation. They're starting trying to help women to conceive, to get pregnant. So every wearable which brings reasonable information and ethical information should be considered as an opportunity.
I would tend to agree with my colleague, but there is something which I think we need to remember, and it is the attitude of individuals to their data being collected. We need to respect an individual in terms of his wishes, his or her wishes, around how that data is collected and if that data is collected. And at the basis of all this, of course, is trust. In a lot of countries, governments are not as well trusted as perhaps they would hope they are by their citizens. And this is a significant barrier to the collection of data we found.
Muchísimas gracias. Esta es la última pregunta que voy a compartir en este momento con ustedes.
Thank you. This is the last question which I'm going to share given the time that we have spent in the webinar. This comes out of the context of workers, of healthcare workers. I am asking it again because it has been repeated. I believe it is considered important. Do you have mechanisms, proposals, evaluations, and follow-up? When working with people that work in prisons, where risks go beyond health to the point in which they may have their lives exposed to danger and other kinds of threats. Please proceed. This is a question for both of you, whichever wishes to answer.
Okay, let me start this time with Dimitar's permission, of course. In one of my previous lives, I was also medical director for the British Armed Forces in Europe. And in this role, we were receiving servicemen and women who came back from the wars in the Middle East in the over the last few years. So we saw what the effect of trauma in their workplace, in their work environment can do to people. And that is even people who we spend a lot of time and effort training to become as resilient as possible. The moment you put them in a situation where there is harm, clearly that is going to have an effect on them. We saw it in the health professionals during COVID. We see it in prisons. Of course, we see it in prisons. They live in a violent environment. We see it in the police force. And our knowledge around managing post-traumatic stress disorder type conditions is not as good as we would hope it is. I think we're getting better at doing this, but clearly it's an issue which I think is not going to go away. Being aware of it is actually the first step in actually managing it better, in my view. Over to you, Dimitar.
So thank you very much. I agree with you, of course, and I think that the name of the game is resilience, what you mentioned. We need to make resilience part of our education, part of our life, part of our job, and part of our thinking, because I don't think that the times will change for better. I think that the times will go for worse, unfortunately. Bogi is a futurist. He can support or deny what I'm saying, but I think that what we need is resilience in every form in our life.
Muchas gracias. En un minuto, para cerrar.
Thank you. In 1 minute to close,
¿Qué mensaje nos dejaría
what
usted?
message
Por
would
favor,
you leave us
Charles
with?
y luego Dimitar.
Please, Charles, and then Dimitri.
Take mental health very seriously. It is a condition which is going to overwhelm us unless we do, and spend as much time as possible empowering people to manage their own care. As we said through this whole webinar, resilience is the name of the game. Over to you, Dimitar.
And never change. Stay cordial, friendly, typical Latin American. This will help you a lot.
Muchísimas gracias a ambos. Bueno, vamos a reiterar el agradecimiento a ustedes, nuestros queridos conferencistas, por
Thank you very much. And now we will wish to restate my thanks to all presenters for their presence today. We have received a lot of comments on our social networks. We also wish to thank to all people present week after week at companies. And very particular thanks to the team of Lorafcom who have always provided their support and unconditional support. Thank you, Ms. Adila, Rove, Ruby, Stephanie. I wish to not mention anyone. Thank you very much for being with us, and to everyone who has participated in this very special activity, in particular Adriana and Javier, who has asked me to express his gratitude to everybody for the invitation, and who also presents his excuses because given the energy crisis, he has been left without a connection for which he had to leave unexpectedly. So this event has been possible due to the commitment of Andean integration. And to conclude, I wish to provide the podium to Dr. Adrian Sen, in name of the Copenhagen Institute of Studies, for the closure of this. Thank you. Thank you. If you will allow me these words in English,
Charles,
so that I can speak directly to Charles and Dimitar. Okay.
I'm very happy with this day and the way it was set up, and also very happy with the collaboration between our institute, Copenhagen Institute for Future Study, and ORAS. And also, of course, I would like to thank my team for this good work. The LATAM team is doing a great work for what we are pushing in Latin America. I think there are a couple of things I would like to mention, some of which we are working with in general that Charles and Dimitar also are included in once in a while. So we have pushed very hard the preventive agenda for many, many years. And exactly in mental health, this is more important than anywhere else. So how do we really push forward? So Albert Einstein is quoted of saying, we cannot solve our problems with the same thinking we used when we created them. And this, I think, is what both Charles and Dimitar were saying with how do we speak intergenerational? It's a different world. How do we use the new technology? So as Charles also was saying that he would dream about sitting an hour with each patient, but that will never happen. So what is the reality that we do, and how do we provide better? So next year in September, alongside the General Assembly, there will be the 4th big NCD meeting on how do we work with the non-communicable diseases. And a part here we have worked with is how do we spend half of the health budget on preventive, primary, secondary, and tertiary prevention? How do we get earlier into people's lives? That's one part of it. But it's also about activating self-care. That needs the trust and data, which was mentioned, and it needs apps, which were also mentioned. How do we work with these things? And it is really about also admitting, which we also heard here, perfection does not exist. So what is good enough to start with, and how do we get the focus on that digital is a part of this way? It's about dignity first and foremost. What do we want? Do we want the best health system or the healthiest population? Digital actually can move us partly out of the constraining hospital into people's life to help them best possible. And this is about resilience, which was mentioned. Resilience is about a society that actually can function and where you catch people based on dignity. We are thinking resilience as protecting the borders with armed people. If your society doesn't have inside resilience, it doesn't matter if you put on cannons on the border. And this is where we really need to change and get the investment too. So I would really like to thank my two good friends here, but also the interventions that we got from Latin America. And this is also about going abroad. And those who know me have also heard me say many times that I think the development we need in this area has a bigger likelihood of being done in a big area like Latin America, where you have 500 million in the same language, where you can work with these things, and where you're not bound into the old system like we are. So please, let's work together and push this forward.
Muchísimas gracias, doctor Boya Eliasson. Y algo imperdonable, se me pasó.
Thank you, Dr. Boya Eliasson. And I forgot something. I wish to thank our esteemed Lourdes and Giselle for the support that they have provided us since the Institute Copenhagen Institute. Thank you, Lourdes. Thank you, Giselle, for the support. And now, well, for the conclusion of this webinar, I am going to now give the podium to Dr. Maria del Carmen, Executive Secretary of Lorascon, who is going to provide now the closing statement. Please, Dr. Kai. Thank you. Thank you. Well, it has been a very interesting webinar. I loved it. The participation of our professors of the United Nations, Bulgaria, comments, questions. I believe that it has been a webinar full of very precious information. I would not know where to begin, but I'm just going to make some comments. I had the chance of being in the Harvard Refugee Trauma Program in Harvard 20 years ago. And one of the most difficult topics was burnout. And I said, but why are you talking about burnout? If here it brought me to learn about violence and how to talk with patients who had suffered from violence, traumatic body, for refugees, for wars, etc. And that's where they spoke about burnout, and that burnout is even more present in workers who talk with patients that have problems of violence and mental health. And I believe that will be the first comment that I would like to make. When it comes to mental health, it's something that has taken years. And this is mental health at the workplace. And I believe that to talk about our healthcare personnel and everything that they have to face, and not necessarily that they have the best tools or the best means to fight everything that they see and that they do, it has been even more required due to the COVID pandemic. And we have healthcare, people have post-traumatic stress, depression, and truly there is a lot of things that happen. And that would be my first comment. And this problem of generation, we have given a lot of grief to the Generation Z. Generation Z has been the top of it, but this is a problem with generations. We have never seen this happen in other. We have now 5 generations together, and the codes for communications are completely different. And I believe that that is part of the tools, part of the attitude, part of the respect, part of everything that we must have of mental health problems. It could be something that has an intergenerational problem. Even for us who are baby boomers, we have to understand the Z, the alpha, centennials, and everything else. They must also understand us. And this is based on 2 things: on knowledge of what interests the other, their desires, expectations, and in the knowledge of what affects the others and how it affects the other generations. I believe that is something that I think that is a topic for a complete seminar. And between these intergenerational issues, communication, which is the same. We live in a different world. It is a different world. So we have to do things differently. We have to modernize. We have to update ourselves. Another thing is about self-help. It is not just something that has to do with drugs or medication. It is about medication, but also it is about self-help that everybody must do. But for there to be self-help, then they have to work on self-help. And for that, you have to have a priority. So help has to have a priority help in the agendas of those who serve in the agendas institutions. I love the picture of Alexis about the elephant. The elephant that was mental health, meaning I'm here, but nobody notices me. I do not know what's happening. So what is being taught to those who are going to be CEOs, who are going to be directors, they tell them a lot about leadership, about the resolution of problems. They have also teach them about mental health. Something that was also very interesting was about giving ourselves these 15 minutes daily. I don't know who said this. And maybe they need to have some more information about what they do. Find a colleague to work with. And because in the end, what is mental health? Because we have to get to know our capabilities. We need to know what we need to do to have a balanced life and to contribute, which has been stated this past few. Mental health is in emergency right now. I believe that is something that was already said, and that is why the Organismo Andino de Salud Andean Health Organization, not just now, since many months ago, in cooperation with the Copenhagen Institute, has spoken about many issues, and what it interests about a lot is mental health, on resilience, on respect, on having a early detection, meaning the earlier we do our diagnosis of mental health, the treatment is going to be even easier and better. I wanted to close by saying that we continue being very interested on this, and we thank many of the people for everything that they have. And we invite you to the third International Congress of Mental Health, which is mental health via life. Because now we have a focus on work. But really, this has to do with everything that we do, and which can lead us and take us to the next stages in life. So thank you very much for everything. Thank you very much, Bojack, to everybody in the Copenhagen Institute, to everybody who has been with Gloria and all the group in Glorias Cono for the work they have done. And we invite you to the webinar number 248 on October 17th. And the subject will be empowering the next generation, which we are very related to for the generation, for a resilient future in the framework of the International Day of Reduction of Disasters. Thank you very much. We'll see you soon. Thank you, Gloria. Thank you, Glorias Cono. And thank you, everybody, Boja. We'll see you soon. Thank you.
Muchas gracias.
Thank you.